Thank you, Dr. Farmer. So good morning. This morning, my ground rounds topic, I'm going to be talking about the health effects of red wine. I have no significant disclosures to make. So I wanted to start off with discussing why I chose this topic. So in deciding what to focus my ground rounds on, I solicited advice on topic choice. Here's what I got. Pick a topic that interests you. Perfect. Pick a topic that applies in which you have experience. Check. Pick a topic that applies to your field. Kinda check. Pick a topic on which you are the expert in the room. I feel that even with my somewhat unconventional colloquial choice of topic, I suspect I am still far from the expert in the room. Oh well, 3 out of 4 ain't bad. So if I'm going to look at effects of alcohol, let's say, on human health, why focus on red wine specifically? Well, there's a fairly practical reason. In turning to PubMed for my research, I first started with health effects of alcohol. Turns out, this is quite a popular subject. Admittedly, some of these results are likely topical alcohol or disinfectant related, but still, almost 40,000 search results gave me pause. For comparison, acute appendicitis generates 22,000 hits, and acute diverticulitis a little over 2,000. So how about just red wine? 485 studies, a little bit more digestible. Now, some of the most exhaustive or compelling data from research performed on alcohol of all types, wine, beer, and spirits, and that data cannot be ignored when trying to discuss wine anyway. However, when convenient or necessary, we may narrow the focus on red wine. So here are the objectives for today. We'll take a brief trip through history. We will learn about the so-called French paradox, an essential phenomenon to be familiar with in order to understand why this area has been so extensively researched in the first place. We will look at the epidemiology of alcohol and wine consumption, of course, discuss health risks and benefits. We will take a look at the benefits of other specific forms of alcohol as compared to wine. We'll discuss the presence of confounding and literature-based evidence, and we'll touch briefly upon future directions as pertains to alcohol and medical research. The consumption of wine dates back to 7000 BC in China. The artwork on the left is a relief on the eastern stairs of a temple in modern-day Iran, and dates back to 500 BC, depicting ambassadors bringing gifts of wine to the Persian king. Production of wine can be traced back to 4100 BC, in a recently discovered Armenian wine cave given the name Areni-1. The Areni-1 Winery was just recently excavated in 2010. Archaeologists unearthed vats and basins made of clay. Scientists also found grape seeds, remains of pressed grapes, prunes, walnuts, and desiccated vines. A number of drinking cups found next to a set of ancient graves were also excavated, suggesting that the site was used for funeral ceremonies and ritualistic purposes. Obviously, the scope of the history of wine is an extensive topic in and of itself, given the wide array of cultures and uses throughout time. But most commonly, wine was associated with either religious or medicinal purposes, as demonstrated by this 13th century artwork of a monk selling sacramental wine in the Middle Ages of France. And on the right is a mural from a palace in Iran of a Persian woman pouring red wine from a decanter in the 17th century. The use of wine in medicine dates back to ancient Egypt in 2200 BC. Evidence of papyrus and tablets describe its use to treat a wide variety of ailments, thus making it the oldest documented human-made medicine. Wine was used to dilute drinking water to reduce risk of contracted diseases. Hippocrates considered wine part of a healthy diet and also advocated its use as a wound antiseptic. There are obvious analgesic properties of ingesting wine that made it useful for treating pain, such as that during childbirth. Wine was also used to treat a variety of non-specific symptoms, including lethargy and diarrhea, etc. The use of wine prevailed throughout the ages with an expanding list of ailments, from blood disorders to infertility, strokes, and even long-term brain damage. Now we fast forward pretty heavily to the 1990s, where renewed interests in highlighting the health effects of red wine came to a head in popular culture and was the topic for a 60 Minutes aired broadcast entitled The French Paradox. The central theme of the French Paradox is that, comparatively speaking, the French eat a diet high in saturated fat. They have a low rate of exercise and yet have a lower incidence of coronary artery disease. The average French citizen eats 108 grams of saturated fat per day, whereas an American eats only 72 grams. The French eat 4 times more butter, yum, and 69% more cheese in their daily diet. However, in 1999, the incidence of death from coronary heart disease among males aged 35 to 74 was 115 per 100,000 in the US and only 83 per 100,000 in France. In an effort to try to explain the reason for this discordant phenomenon, Dr. Serge, I apologize, I'm probably going to butcher this name, Dr. Serge Renaud, a native of Bordeaux, posited that this observed difference was due to the French consumption of red wine, which is rich in antioxidants and has a beneficial effect on platelet function. Here's a clip from the 60 Minutes aired broadcast explaining the basics of the French paradox.
The farmers have been eating this for years. They've been eating a very high-fat diet, it seems, and yet they don't get heart disease. If we took the same diet and put it into an American, we would all be suffering from carnivores at an early age. There's something about the French that seems to be protecting them, and we're not sure what it is. We're looking for it.
It looks a lot like Dr. McVicker. I'm really bothered me. It's not. I checked the credits. If you have time, the 15-minute segment is interesting and worth a watch. They go on to acknowledge the possibility of the role of fresh versus processed foods, number of meals per day, the role of dairy fat, and explaining the paradox. However, the documentary eventually returns its focus to red wine.
There has been for years the belief by doctors in many countries that alcohol, in particular red wine, reduces the risk of heart disease. Now it's been all but confirmed. The wine apparently affects the platelets, the smallest of the blood cells. It is platelets that cause blood to clot. They prevent bleeding. But they also cling to rough, fatty deposits on the artery wall.
It's like amateur cartoon sketch.
Finally blocking the artery and causing a heart attack. The wine has a flushing effect. It removes platelets from the artery wall. So the answer to the riddle, the explanation of the paradox, may lie in this inviting glass.
It's well documented that really a moderate intake of alcohol prevents for coronary heart disease by as much as 50%. I mean, this is
50%.
50%. I mean, there is no other drug that's being so efficient than a moderate intake of alcohol. Of course, the problem is that people are tempted to go beyond this moderate intake.
When you say a moderate intake of alcohol with meals, what do you mean?
I mean a few glasses of wine per day. If you're just sticking to that, you will never get drunk. You will never get apparently any adverse effect of this intake of alcohol. Alcohol is a drug, and as any other drug, it has to be given at a proper dosage.
So just as long as you stay within a couple, 2, 3, 4 drinks a day, you should be fine. But there's a lot to digest in that short segment, so let's take a look at a few things. First, let's define consumption. According to the dietary guidelines for Americans published by the U.S. Department of Health and Human Services and the U.S. Department of Agriculture, moderate drinking is defined as up to 1 drink per day for women and up to 2 drinks per day for men, or 7 drinks per week for women and 14 for men. Heavy drinking is simply defined as volumes greater than that. The obvious problem with this definition is the word drink, since that has obviously variable definitions depending on the enthusiasm of the imbiber. Therefore, the National Institute on Alcohol Abuse and Alcoholism, as part of the NIH, standardized the alcohol content in grams of 14 grams per alcohol per standard drink in order to achieve a more uniform definition. Furthermore, in the United States especially, wine is oftentimes higher than 12% alcohol by volume concentration. To address this, the NIAAA also provides a drink size calculator on their website to provide you with the information to determine how much volume would constitute one standard drink based on the ABV of the beverage. Totally fun killers in my mind, but here you can see the countries with the highest annual per capita wine consumption. In France, for example, the average person consumes 42.5 liters of wine annually, which amounts to about 2/3 of a glass per day. In the US, the number drops to about 1 ounce, or 1/6 of a glass of wine per day. Atop the list is Vatican City, likely related to the number of Catholic masses and wine consumed for religious ceremony. In case you're curious about all forms of alcohol, not just wine, this data from the Organization for Economic Cooperation and Development shows the countries with highest per capita alcohol consumption. Interestingly, compared to the list of wine consumers, only France and Austria are in the top 10 for both wine and total alcohol consumption. A lot of European countries on top of this list may achieve higher marks due to consumption of other forms of alcohol, such as hard liquor and beer. The US ranks 25th on this list. Despite our comparatively low rates of consumption, the abuse of alcohol still carries a significant social and economic burden in the US. Alcohol use disorder affects 8% of men and 4% of women greater than 18 years old. Alcohol is accountable for 88,000 deaths in the US annually, making it the fourth leading cause of preventable death, and is responsible for 31% of motor vehicle fatalities, though I suspect that may be a low estimate. Alcohol misuse or excessive consumption cost the US an estimated $249 billion in 2010. 75% of that cost is attributed to binge drinking. Worldwide, 6% of deaths are attributable to alcohol, also making it the fifth leading risk factor for premature death or disability among people ages 15 to 49. The negative effects of alcohol on society and economy are well known, as are the numerous negative impacts of heavy alcohol consumption on the human body. Alcohol is one of the most common causes of liver cirrhosis and accounts for 30% of cases of acute pancreatitis. The effects of alcohol on the cardiovascular system include cardiomyopathy and arrhythmia. At higher doses, alcohol is associated with increased risk of coronary artery disease and stroke. Alcohol use has been associated with the development of an array of cancers in the oropharynx, upper GI tract, breast, liver, colon, and rectum. Further sub-analysis showed that heavy consumers were at the highest risk. In some cases, these diseases, such as alcoholic fatty liver disease and mild alcoholic hepatitis, are reversible with abstinence. In other instances, however, such as the case with cirrhosis or pancreatitis, these conditions are often not reversible, though abstinence may slow disease progression and/or decrease severity of symptoms. Some studies find even stronger associations with alcohol consumption and cancer. In this meta-analysis, even 3 to 4 glasses of wine per day increases risk of esophageal cancer by 70%. Those drinking 5 to 7 glasses of wine per day suffer 4 times increased risk and 7 times increased risk of oropharyngeal cancer. These increased risks of cancer from alcohol must, however, be kept in perspective. It is often the role of alcohol in conjunction or combination with other significant risk factors that can affect the overall cancer risk. The use of tobacco, for example, is often unaccounted for in these studies and is second only to diet and modifiable risk factors for the development of cancer. In addition to the effects of heavy alcohol consumption on a large number of medical diseases, it turns out that alcohol also affects postoperative risk. In a meta-analysis review of 55 studies published in the Annals of Surgery in 2013, the effect of alcohol consumption on development of 30-day postoperative complication risk was assessed. The authors found that the intake of alcohol greater than 24 grams per day in women and 36 grams per day in men, that's about 1 to 2 in women and 2 to 3 in men, of drinks, increased your risk of overall morbidity, infection, wound complications, pulmonary complications, prolonged hospital stay, and ICU admission. Additionally, heavy drinkers were at greater than 2.5 times the risk of mortality within 30 days following their operation. Other studies show similar effects of alcohol on wound healing, where heavy use is associated with a 2-fold increase of risk of wound infection. These data demonstrate the adverse effects heavy alcohol use can have on surgical patients as well. Okay, so not all news is bad news. In 1926, biologist Raymond Pearl investigated the effects of alcohol on chicken progeny at the Institute for Biomedical Research at the Johns Hopkins University. When he discovered that alcoholized fowls lived, that's a really hard word to say, lived longer than those who got nothing but plain food and water. He later collected data on a large group of white working class people, ages 15 to 99 years old in Baltimore, Maryland. His conclusion, published in the 1926 book Alcohol and Longevity, was, in a fairly large and homogeneous sample of the working class population of Baltimore, the moderate drinking of alcoholic beverages did not shorten life. On the contrary, moderate steady drinkers exhibited somewhat lower rates of mortality and greater expectation of life than did abstainers. Those persons in this experience who were heavy drinkers of alcoholic beverages exhibited considerably increased rates of mortality and diminished longevity as compared with abstainers or moderate drinkers. Graphical representation of this data relationship between alcohol and mortality was later published in a newsletter by Dr. Ronald Unzelman and is credited with the first of the so-called J-curve graphical representations of this phenomenon. The essence of this graph is that although heavy alcohol use is clearly associated with increased mortality, there appears to be a benefit in moderate consumption even over abstainers. Since that time, the J-curve has reappeared in numerous publications studying the association between alcohol use and various health benefit outcomes. Proponents of this observation would point out that this relation has been established in a series of studies, starting with the Framingham study, the cancer prevention study in almost 500,000 people, to the Copenhagen City Heart Trial. This J-curve data trend has been found when analyzing total mortality, cardiovascular disease, and stroke, and we'll take a look at each of these briefly. Numerous studies from the 1970s onward have reached a general consensus. People consuming 1 to 2 standard drinks per day appear to have a lower cardiovascular event rate than persons abstaining from alcohol, a prime example of the J-shape, or sometimes U-shaped curve. Estimates of the risk reduction have ranged from 20 to 30%. In one of the largest and most comprehensive meta-analyses evaluating this association, published in the British Medical Journal in 2011, Wrongsley and colleagues reviewed 84 studies totaling over 1 million people. They concluded that the pooled adjustment for relative risk for alcohol drinkers showed they were 25% less likely to die from cardiovascular disease compared to non-drinkers. Furthermore, dose-response analysis showed that the lowest risk of death from coronary heart disease occurred with consumers of 1 to 2 drinks per day. These data have been echoed by many studies published from 1991 through 2017. Each demonstrating similar data trends for a reduced risk of cardiovascular disease in light to moderate alcohol consumers. Also repeatedly demonstrated is the negative effects of higher levels of alcohol consumption, hence the J shape. As far as possible mechanisms to explain this benefit, the effect of alcohol on levels of high-density lipoprotein, or good fat, is commonly regarded to contribute the largest effect. Increased HDL is thought to be the result of increased hepatic synthesis. A study published by authors at the Harvard School of Public Health and the New England Journal of Medicine in 2001 seemed to support this association. They studied 396 patients in the Physician's Health Study and matched each of these patients with 1 to 2 control patients. They characterized their genotype with respect to the function of their alcohol dehydrogenase enzyme activity. The authors demonstrated a reduced risk of MI in moderate drinkers in both groups. However, those individuals with slower metabolism had the lowest risk. Furthermore, the HDL levels of these patients were significantly higher than those with faster alcohol metabolisms. The authors concluded that moderate drinkers who are homozygous for the slow oxidizing allele have higher HDL levels and a substantially decreased risk of myocardial infarction. In terms of total mortality, the most comprehensive work thus far seems to have been done by a group of authors from the University of Milan, published in the Archives of Internal Medicine in 2006. They performed a meta-analysis of 34 studies comprising over 1 million subjects, evaluating the relationship between alcohol consumption and overall mortality. Once again, these researchers found a dose-dependent J-curve association between the number of drinks per day and total mortality. They concluded that women who have 1 to 2 drinks per day and men who have 2 to 4 drinks per day have lower rates of overall mortality by about 17 to 18%. Heavy drinkers, again, had higher mortality rates. In 2006, researchers from Columbia University performed a large prospective cohort study to look at risk factors for stroke in a multi-ethnic urban population in New York. They compared moderate alcohol consumers to people who had not had 1 drink in the past year, as well as complete abstainers. They controlled for the presence of medical comorbidities. They found a lower relative risk of the development of both ischemic stroke alone, as well as the composite outcome of ischemic stroke, myocardial infarction, or vascular death compared to both non-drinkers and abstainers. These data suggested a 26 to 33% reduction in risk of stroke, MI, and/or death among moderate drinkers. Studies on dementia have had similarly positive results. A meta-analysis of 23 studies published in Age and Aging in 2008 showed a decrease in the incidence of dementia and Alzheimer's dementia in moderate drinkers above 65 years old. There was no association between alcohol intake and the development of vascular dementia or generalized cognitive decline. The authors also commented that their subgroup analysis of studies showed that wine drinkers had the greatest overall benefit. However, in their own words, not conclusively so. A study published in 1997 involving the prospective analysis of almost 3,800 patients was conducted in 2 regions in Bordeaux, France. Wine was the only alcoholic beverage reported by 95% of people. The subjects were followed for 3 years and their daily alcohol consumption was recorded. After adjusting for age, sex, education, occupation, baseline MMSE scores, and other possible confounders, the authors found a substantially reduced risk of developing dementia and/or Alzheimer's in mild and moderate consumers. Moderate consumers had a 70 to 80% reduced risk of development of Alzheimer's or dementia. Light drinkers had a 45% reduced risk of developing Alzheimer's. A summary article published in the journal Diabetes in 2014 outlined both epidemiological and metabolic studies on the association between consumption of alcohol, specifically red wine, and the development of type 2 diabetes. The authors cited 5 large epidemiological studies that analyzed this association, totaling around 670,000 patients. The authors concluded that moderate drinking of alcohol was not associated with increased risk of type 2 diabetes, and furthermore, wine drinking specifically seemed to be protective. They summarized small volume metabolic studies that address the effects of moderate alcohol consumption on fasting glucose, glucose tolerance, and oxidative stress. In one particular study, for example, subjects were randomized to drink either red wine, tannic acid, or 16 grams of ethanol in water with a midday meal. The group that drank red wine and tannic acid achieved better glucose control than water and ethanol alone, which also raises a very significant question itself. Is it the alcohol or the non-alcoholic components of wine that seem to confer its health benefits? It is widely believed that the grape skins contain the most likely source of metabolically active beneficial compounds, and these chemicals impart their benefits through antioxidant properties, working at least in part through removal of DNA-damaging oxygen-free radicals. Polyphenols are a group of chemical substances found in plants, and flavonoids are the most abundant polyphenols found in the diet. Tannins of the wine contain these flavonoid polyphenols. The highest concentrations of tannins are found in the grape skins, and to an extent also the seeds and stems. The longer the wine is left in contact with these parts of the grape, the higher the concentration of polyphenols. Red wines, and not white, are fermented with their skins and thus spend the most time in contact. Resveratrol is the most commonly studied individual polyphenol antioxidant that is present in grape skins. The varieties with the most resveratrol in the wine include Malbec, Petit Syrah, and Pinot Noir. Resveratrol belongs to a class of molecules called phytoalexins, which are actually antibiotics produced by plants when under attack by pathogens such as bacteria or fungi. It is still unclear why resveratrol has received so much attention, especially given its relatively low concentration compared to flavonoids in general. Evidence suggests it may be due to early studies showing a potential inhibitory effect on cyclooxygenase, but these data have not been thoroughly explored. Scientists have reported that the antioxidant activities of 1 glass of red wine is equivalent to 2 cups of green tea, 3.5 glasses of blackcurrant juice, 3.5 glasses of beer, 4 apples, 5 servings of onion, 5.5 servings of eggplant, 7 glasses of orange juice, 12 glasses of white wine, and 20 glasses of apple juice. To support this assertion, several researchers have attempted to isolate the effects of non-alcoholic red wine components to determine a positive association with health. Researchers in Italy measured antioxidant capacity for 6 hours following a meal with or without wine, finding increased capacity following meals with wine consumption. In a crossover study with men at high cardiovascular risk, subjects were given red wine, non-alcoholic red wine, or gin with dinner for 4-week periods. They found fasting insulin levels to be lower with red wine and non-alcoholic red wine compared to gin. A study by Nakamura and colleagues was performed on patients with type 2 diabetes and nephropathy. Subjects were given 118 milliliters of red wine or white wine for 6 months, and compared to a group with no wine given. Only the group with red wine, not white, had a reduction in markers of oxidative stress and declining renal function, suggesting a positive effect on diabetic nephropathy from non-alcoholic components of red wine. Studies performed on resveratrol specifically have shown an increased lifespan and health for mice who are given resveratrol in the setting of a high-calorie diet. Some preliminary evidence also suggests that resveratrol in humans may have anti-inflammatory effects, prevent cancer, diminish arterial stiffness, and improve endothelial reactivity in older women. In a randomized trial of 20 healthy adults, plasma concentrations of CRP and TNF decreased by about 1/3 during 6 weeks of supplementation with a plant extract containing resveratrol. Although there has been success in demonstrating the antioxidative and anti-inflammatory effects of resveratrol and other polyphenols, the impact of these compounds in vivo and epidemiological studies is lacking. In a recent study published in JAMA 2014 by Dr. Semba and colleagues at Johns Hopkins, performed on 783 men and women living in the Chianti region of Italy from 1998 to 2009, total urinary resveratrol metabolite concentration was not associated with inflammatory markers, cardiovascular disease, or cancer, or predictive of all-cause mortality. As an interesting aside, some researchers found that resveratrol has a relaxation effect on the human gallbladder. Their work showed this relaxant effect to be dose-dependent and associated with nitric oxide-mediated pathways. We may not be quite at the level of changing the algorithm for the management of biliary colic, but it is certainly an interesting and unexpected finding. As far as red wine versus white wine, there has been no good epidemiological study to firmly establish any clinical outcome benefit of red versus white wine drinking in Europe. In the United States, epidemiological studies have not shown any particular difference between red and white wine in terms of cognitive protection, cardioprotective effects, or overall mortality. Some studies, however, do illustrate some benefit in drinking red over white wine. In a study published in Lancet in 1999, the authors took 10 healthy human volunteers in a crossover study, during which time they consumed 1994 Chateau Bechevel, 1997 Chablis Moreau, or vodka diluted to an equal alcohol content. They found a significant increase in coronary flow velocity reserve after drinking red wine, but not after drinking white wine or vodka. Drinking red wine raised HDL cholesterol and plasma antioxidant status more than did an equivalent dose of white wine when given to healthy volunteers. In vascular smooth muscle cells, red wine, but not white, inhibited the PDGF beta receptor that is crucial in the development of atherosclerosis. Conversely, incubating white wine with grape skins endowed white wine with a similar power of inhibition of LDL oxidation to that exhibited by red wine. In human mononuclear cells incubated with VLDL, drinking moderate doses of red wine, but not vodka, inhibited the activation of NF-kappa B, thus providing an anti-inflammatory mechanism. These comparative studies seem to support the red wine hypothesis. There is good news for beer drinkers also, which I'm sure will make several members of this residency program fairly happy. In 2011, Simona Costanzo and colleagues performed a meta-analysis on 16 studies covering almost 290,000 healthy adults. Evidence confirmed a J-shaped relationship between wine intake and vascular risk. Similarly, from 13 studies, a J-shaped relationship was apparent for beer with a maximal protection of 42% at 43 grams per day of alcohol. So in other words, about 3 beers per day protected from cardiovascular events by 42%. From 12 studies reporting separate data on wine or beer consumption, 2 closely overlapping dose-response curves were obtained, suggesting an equal benefit of beer and red wine. In the meta-analysis of 10 studies on spirit consumption and vascular risk, no J-shaped relationship could be found. A consensus document by authors in Italy published in 2016 stated that low-moderate, non-binging beer consumption reduces the risk of cardiovascular disease. This effect is similar to that of wine at comparable alcohol amounts. They also concluded that, although there is mild evidence for similar neuroprotective effects between beer and wine, there are fewer studies and the evidence is not as strong. Beer also demonstrated similar positive effects on all-cause mortality and impacts on the risk of development of cancer compared to wine. So, to put all these studies into context and simplify, heavy alcohol use is uniformly associated with higher mortality. It appears that alcohol at low-moderate doses may have a positive effect on reducing risk of cardiovascular disease, stroke, diabetes, dementia, and overall mortality based upon epidemiological studies. And red wine in particular may have the strongest association. This may be, at least in part, due to non-alcoholic components such as resveratrol and other polyphenols. Beer seems to be largely equivalent to wine with respect to reduction of cardiovascular disease risk and overall mortality. Unfortunately, the data on spirits is not as convincing. That being said, we cannot ignore the enormous presence of potential bias and confounding in these studies. Though some studies attempt to statistically account for the presence of comorbidities, there are often other risk factors that are omitted or not included in analysis. A Danish study reported that young wine drinkers overall have a higher IQ, higher parental educational level, higher socioeconomic status, and higher psychological functioning compared to beer drinkers of the same age. A little controversy there for you guys. Also, consumption habits among drinkers vary. Most drinkers do not exclusively drink one type of alcohol, and timing of wine or alcohol with meals may have an unknown impact. Also, since some of these studies are based upon averages, the overall occurrence of binge drinking is not always known. Wine drinkers tend to have more favorable cardiovascular risk profiles in general compared to both beer drinkers and abstainers, and socioeconomic factors obviously play a large role. Tobacco use is not always accounted for in these studies, which obviously plays a large role in cancer risk and mortality. The phenomenon of underreporting has been detailed in the literature, which may both downplay the positive effects of moderate consumption as well as misclassify former heavy drinkers in poor health as abstainers. As people age and become unwell, they are more likely to quit or substantially reduce their alcohol consumption, leading to an exaggeration of the already poor health effects of abstainers. Then, given the number of meta-analyses, the variability in study design and quality makes overall conclusions more inaccurate. In an attempt to address these issues of bias through statistical adjustment, Stockwell and colleagues performed a meta-analysis on over 4 million individuals, comparing alcohol consumption to all-cause mortality. They cited the trend of abstainers being biased toward ill health as the inspiration to try to control for quality-related study characteristics. In their unadjusted results, they were able to replicate the J-curve association demonstrated in numerous other publications, showing a decreased overall mortality for moderate alcohol consumption. After adjustment for abstainer biases, however, the authors found no significant reduction in mortality risk for low-volume drinkers. The authors therefore concluded that estimates of mortality risk from alcohol are significantly altered by study design and characteristics. Meta-analyses adjusting for these factors find that low-volume alcohol consumption has no net mortality benefit compared with lifetime abstention or occasional drinking. So where does that leave us? Hours researching this topic has made clear the sheer difference in number of studies reporting a positive association between alcohol or red wine and various components of health, while far fewer studies are pointedly trying to demonstrate flaws in these conclusions. In trying to answer the simplest of questions, is wine good for you or bad for, Dr. Bolt's probably in his case, but this is the closest you're going to get for us giving you a bottle of Screaming Eagle. There are so many permutations of studies and study designs that answering such a simple question is all but impossible. Studies differ on type of alcohol, wine, beer, spirits, volume of ingestion, frequency, what outcomes are being measured, antioxidant properties, the results of blood tests, urine samples, overall mortality. Is this in rats, humans, French people? It is all fairly overwhelming. It may be contentious in these current times to argue that we should look to our government to make truthful, well-thought-out statements or recommendations. But it is worth noting that from the American Heart Association, the American Diabetes Association, to the British Heart Foundation and the World Health Organization, these governmental agencies either cite moderate alcohol intake as beneficial or at least do not entirely discourage its use. Observational cohort studies and meta-analyses are yielding diminishing returns, and future research should ideally move in other directions. Attempts to perform randomized control trials of the effect of alcohol and disease outcomes would certainly be of interest, but logistical difficulties seem nearly prohibitive, and firm conclusions are unlikely to be developed. If I tried to enlist subjects from this very room who would be volunteering the freedom of their beverage choice to a 50% possibility of placebo non-alcoholic sour juice for a period of some years, I think I might have difficulty with recruitment. The study of what people drink and why is still in its youth and may help to uncover some of the biases and confounding factors behind present-day literature. As the field of genetics research grows and expands, factors related to the risk for development of cardiovascular and other diseases may help to complete the picture of alcohol-mediated positive effects and help to predict disease susceptibility in subpopulations. Those patients with known cardiovascular disease taking medication also consume alcohol, and the interactions between these medications, potentially adverse or synergistic, are not currently known. Perhaps there is a capacity to identify patients at particular high or low cardiovascular, neurologic, or oncologic risk, and make individualized recommendations for alcohol consumption based upon current data. This area has not been explored. Lastly, identifying significant risk factors for the progression from light moderate to heavy drinkers and alcoholism would help to predict those at highest risk and be an important component of any recommendation endorsing alcohol consumption. In the end, I think it's important to note that when it comes to evaluating the potential health effects of wine or other alcohols, you see what you want to see. The plethora of research on the health benefits of alcohol and wine are all inherently flawed by the same shortcomings of data collection methods and data judging meta-analyses. It seems almost as if the same flawed core data is being recycled, rewashed, and represented, citing each other as growing evidence when novel data is fairly uncommon. Regardless, these trends are worth noting, and until studies begin to tip the scales to show more solidly negative effects, the current data may not change behavior significantly. It's hard for some to ignore the unmeasured joy of company, good food, time well spent with family and friends, sharing a glass of wine and laughter around the dinner table. To some, wine is an essential part of the enjoyment of a delicious meal. To others, it is a living, and these intangibles will forever be impossible to quantify. I'd like to start by thanking my wonderful wife, Annalise, for supporting me throughout the entirety of residency and begrudgingly letting me give my grand rounds on this topic. To my co-residents, family, and friends who either directly or indirectly inspired my research. To my mentors and all the faculty here at UC Davis for making this such an amazing place to grow and learn. To Dr. Escalante and Farmer for creating and supporting a fantastic department of surgery. I'm excited to see all of you that can make it to the Chief Banquet this weekend. We'll put the theories and conclusions discussed today to a thorough test. Thank you very much.
Really fun. What can I say? And I promise we won't be randomizing people on Saturday night. Questions for Noah?
So you have socially accepted drugs. You think about alcohol, you think about caffeine. So one hypothesis could be that since we've been exposed to these drugs for thousands of years, as we evolved based on the use of them so that they're better for us. If we had started from 7,000 years ago, we never took alcohol, would have made a difference. So one hypothesis could be that since we've been refining these drugs for so many years, that's why they're beneficial versus the guys who take methamphetamine, which is new and it comes to the brain every day. We haven't evolved.
I mean, that's an excellent point. There's probably some value to being less afraid from saber-toothed tigers after a glass of wine or two, and some probably evolutionary benefits there. That's certainly a very good point.
So here at UC Davis, the Department of Nutrition actually conducts a lot of studies on Resveratrol and other nutritional agents that help with cardiovascular disease. One of the trials we're involved in now is taking grapes, like Cabernet raisins, and making grapes that you make Merlot or Cabernet, and make these little raisins with them. We call them Cappa raisins. And they actually have the stems and seeds in them. They're different than standard raisins you get from Sunkist or whatever. The skins are thick. They don't taste as sweet. But we're studying these in the patient population of postmenopausal women to see if we can reverse some of the anti-aging or anti-cardiovascular effects. And so far, we don't have a lot of control data, but there may be something in the future. So keep an eye out for that. I can send you some samples.
Yeah, I'll keep a room for a couple slides for the next time I
Exactly.
give this.
You can bring raisins to dinner.
Yeah,
Graduation.
raisins would have been kosher for grand rounds.
Have raisins. There you go.
Hey Noah, where is the picture on the left?
That's from New Zealand. That's from our honeymoon in Central Otago. So actually, it's the southernmost winemaking region on the planet. Central Otago, New Zealand. I highly recommend you go. It's beautiful, obviously, and the Pinot Noir in that region is very good. High in resveratrol.
Famous surgical oncologist is from that area where he went.
Oh, really?
Yeah.
Huh.
One more thing. So I took the Surgeons and Leaders course, and in that course, Larry Kaiser gives a whole talk on surgeons that are involved in the wine business, or physicians in general. And Turley, you know what Turley did?
He's an emergency room physician. That's, I mean, obviously you recognize him?
Yeah. Well, that's true.
Yeah, that's Larry.
No, where you go.
Oh,
We've seen recently how special interests shape not only research, but our perception of research into nutrition, and can alter that perception for generations, whether it be the balance between sugar and fats and all those sorts of things, whether it be that archaic food pyramid that the USDA put out when in the 80s or 70s or 80s. What influence would you say special interests is having in either promoting or suppressing the research that you were?
Yeah, I mean, multiple authors in their publications I came across bring that up. And it's, sadly, I think it's impossible to see all that is going on sort of behind the scenes. I mean, you have a bunch of studies that say, here are some health effects. And the opponents seem to be saying, well, there's flaws in those studies, rather than somebody coming out and saying, look, we took people who didn't drink, we took moderate drinkers, and they don't do better, they do worse. And maybe there's not a lot of data sort of making that hypothesis, and that's probably, what's being suppressed by sort of big industry, unfortunately. That'd be impossible to see. But I think, a lot of that initial data, the epidemiological studies, the meta-analyses, I can completely understand how industry would be driving that.
So I have to say that on the plane, and I just looked it up again in the British Medical Journal 7 days ago, they just came out with a 40-year cohort study following 500 people. It's in the Framingham study, kind of like the old study out of Boston here, that suggests that moderate drinkers have an increased risk of dementia-related brain changes on MRIs over time. So I wasn't going to throw that cold water on it since you brought it up.
Well, Dr. Bold brought up a study too that was on NPR about they took these two scientists went to Oktoberfest, and they hooked a whole bunch of people up to actually Holter monitors and did breathalyzer tests on all these people drinking a whole bunch of beer, and found obviously an increased risk of arrhythmias and acutely those sorts of things. That's fairly novel data, but certainly an interesting experiment set up to think about.
They're just trying to write off their trip.
Yeah, that's right. In fact, they do admit that they participated in the Oktoberfest celebration.
Well, thank you again, and I'm sure there's much more work to be done. That's great.